SIS. Oh, and so in terms of what I do, the SIS clinic sees HIV positive patients as well as those co-infected with hepatitis C and hepatitis B. We basically arrange treatment, blood work, testing, and care for people who are positive for HIV. Every one of our patients that we see has HIV, and we are essentially involved in their care. There's 6 doctors that rotate through here. I am the pharmacist for all of them. So I help arrange medications, coverage, as well as kind of resolving any sort of drug therapy problems. I check for interactions. And there's a lot of logistics that I do as part of my job as well, just to make sure that everyone has the medications they are prescribed, that they can access them without barriers to coverage, and that we've made things as smooth as possible for them.
Oh, thank you so much, William, for that. And Dr. Priye?
Hi everyone, my name is Dr. Dia Priye Tamnatoko. I'm a medical doctor, and I used to work with Center for Disease Control Atlanta, where I worked as a clinical mentor. And what I did back then was I was able to mentor healthcare workers, healthcare providers, doctors, nurses, labs, and all that on the best approach and the best practices to manage positive patients, because some of them don't really know deep down on how to manage a positive patient. They know about how to manage patients, but not the positive ones. And so we put them through the guidelines to follow, and then we follow up on them to ensure that they are truly following those guidelines. And currently, I'm a volunteer with Positive Health, where I also assist in counseling positives who are from my country, Nigeria. And I think I've met some of them already. And so far, so good. It has been a good experience, and I hope to get more of that. Thank you.
Thank you so much, William and Priya. So at the end of this discussion, we're hoping that we'll have an understanding of the unique challenges that are faced by mainly newcomers in accessing and actually navigating the HIV care system in Canada, right? And we'll also be able to define what we would call a culturally appropriate care in the context of HIV management. And we also maybe will be able to identify systemic and service level gaps in management of HIV, and also explore best practices as well. And we also foster inclusive dialogue here. So maybe just to set the stage, I will start with you, William. I think my question would be on newcomers especially, and refugees who are new to come to Canada. So maybe you can set the stage for us in terms of when newcomers and refugees are tested for HIV as part of their immigration process, and how and when do you get involved as a pharmacist?
So for the SIS, every patient that we have is positive. Usually immigration is what screens people coming into the country. And I've seen them do it at different points. So when you enter, they do the screening tests. Sometimes during visa extensions as well, they do additional screening. I've seen patients who have come in on a visitor's visa, and then when they want to extend their stay or they want to apply for a different form of, I guess, staying coverage sort of thing, the government will test you just to make sure that you're cleared medically. And at those points, they detect that they're positive, and then they get referred to a clinic. So in terms of our catchment, we take care of Hamilton as well as patients as far as Niagara, even sometimes almost to London as well. So patients who are coming to the country, they tend to go through Niagara, and then they go through the SIS clinic if they are positive. Most patients who we see in the clinic know their status. They've already been on treatment from their home country, and they get picked up on the way in. So it's not really a surprise for most of our patients. For a couple of them, it is done on screening. I've seen a few patients who were actually sponsored refugees. We had one who was pregnant, and we detected as part of prenatal screening. So I get involved when, usually for patients who are already on medications, when they're running out. So if they've been referred to our care and they haven't had a chance to see the physician, they're running out of medications, I will intervene. So that way there is no interruption in treatment. So in those cases, I'll flag them to our physician. We'll review choices that we can switch them to in terms of medications that would be equivalent, effective, and also establish coverage. And the other cases where I get involved are usually continuations. So they've had their meeting with a physician. We want to switch them to something that is available in Canada, and that might not actually be the same as what they've come in on, or if we're modernizing medications as well, at least for newcomers. For patients who are domestic or who have been long-standing patients, we're constantly modernizing their regimens as well, because new drugs are always coming out with different benefits, less interactions, easier adherence, and it's essentially a great way to engage patients in care, keep them involved with us, and also improve health outcomes. And it's for everyone. Well, like we do reviews for everybody's medication and make sure that they're on an appropriate regimen that will, foster long-term success.
Oh, thank you so much, William, because you've already answered the next questions that I had. I was going to ask you how often people actually find out their HIV status through the immigration system, and also I was going to ask you for those that people that come into the country already knowing their HIV status, if they come with their prescriptions already and their care plans, and how you integrate that with the system that's new to them.
So when patients come in,
Hmm.
I'd say it's only a minority that don't know their status.
Okay.
And in those cases, we try to fast track them to be
Hmm.
seen by a physician. We'll do their blood work as soon as possible because just according to the research, the faster you start a patient on HIV medications, the better the health outcomes.
Hmm.
The sooner you diagnose them, the sooner they're on treatment, the better control we have just down the line in terms of just preventing viral resistance or just addressing adherence challenges as well. When patients know their status and they do come in with medications, the biggest problem is actually supply. uh, I'd say like 95% of the patients who are coming in who have medications are on
Hmm.
TLD. That's tenofovir, lamivudine, dolutegravir. That is the most popular regimen currently outside of Canada.
Okay.
That is
Hmm.
not available in Canada. So
Oh.
yeah,
Hmm.
maintaining drug supply is therefore a challenge. A lot of patients have some way of getting medications either shipped to them by family members from home, or they bring in an incredibly large amount with them. But there is a wait time to see our physician, so sometimes there's a risk that they'll run out. In those cases, I'll check how much they have during their intake visit. And then depending on how their lab work resolves, how much they have on hand, we might be able to switch them to something we have domestically. And in terms of our choices domestically, I'll look at what is covered. For patients who have no drug coverage,
Hmm.
either from the government or what have you, there are ways to obtain coverage through the manufacturers generally, but only for select medications. So
Okay.
a lot of it is just balancing the therapeutic need versus what is available.
All right. So can we safely say that that's the biggest challenge, having to change the medication that one is taking and having them to see a physician when they come here, and that they may run out? Would that be the main challenge that one would face if they were to uh,
Yes.
want to be? Yeah.
From a pharmacy perspective, I believe so, because if you've just found out you're diagnosed, we need to get you in as soon as possible to run blood work and check you out. For patients who already know their status and are already on treatment, interruptions in treatments are probably the worst thing to happen. So that is our major prerogative, to prevent any interruption in therapy. Because if you interrupt therapy, especially intermittently, that gives rise to resistance, which then eliminates entire classes of medications that we can use. If we can
Okay.
prevent interruptions in therapy, that automatically already brings you into our system, right? We establish coverage for you. We establish a prescription that is tied to a infectious disease physician. We're able
Okay.
to basically make you a part of the Canadian healthcare system just from that. At least that's my perspective.
Wow. Yeah, you explained it very well. Maybe one last question to you. How would you say somebody's immigration status, whether they're just a newcomer or somebody who's trying to change their visa from being a visitor, maybe to want to stay in Canada if they're a refugee, if or whatever, just a person's immigration status or their language or their would you say that that has an impact on how they walk their HIV care journey, like the language or any cultural stigma that you may point out to?
So anything like that can be considered a barrier
Hmm.
because it can always hinder care. The inability to communicate directly between two people
Hmm.
is problematic. To get around that, the clinic actually has translation services that we are able to book ahead of time, or we can request on the fly. But even then, you're going through an intermediary. So it
Hmm.
is not ideal, but it is our attempts to remove barriers to treatment. We also have a very diverse staff. So we have nurses who speak Spanish, French, English, Chinese, and
Of course.
and even our physicians, they speak a myriad of languages to best provide care. And we actually try to match patients with a physician who might be able to speak the language that they're actually speaking. Um, and it is difficult, but we find ways around it. And I think that is the most appropriate way to kind of approach treatment. Just remove as many barriers as possible, but it does make things harder. However, we don't discriminate who can come to this clinic. If you have no coverage, the SIS will waive your fees. You just need to speak to our social worker and they'll be able to get you coverage under compassionate grounds. I can get patients medications under compassionate grounds. Because we have so many HIV patients, our relationship with the manufacturers for drugs is actually quite good. So I'm usually able to help out, at least on the medication side of things. As long as people talk to us and are willing to engage, we'll do whatever we can.
Oh, that's so interesting. So I'd want to believe that maybe as a person who's coming for services, the other thing that people would fear is the confidentiality issues around that. So how do you make sure that they're confident, they're actually assured that everything that you talk about, even though there's a person in between doing the translation and all, that everything that they talk to you about is confidential and well, you know, kept.
So that is more of a legal thing. So
Okay.
PHIPAA guarantees that all medical records are confidential between your provider and the
Hmm.
patients themselves. And the voice translation service that we use are also bound by those legal rules. They cannot disclose anything. Otherwise, they break the law. And it is, I believe, a federal law. So it's not even a small kind of rule breaking, it is quite large. And even with um, drug companies and insurance and things like that, they're all separated entities. And it is a concern that a lot of patients have brought up. They're afraid that if they get HIV meds and it's paid for by an insurance company from their employer, that their employer would find out. That is not legal. They
Hmm.
can't do that. And an employer can't even get records to what medications are reimbursed. To kind of create a structure where that isn't an issue, there's actually adjudication companies that pay for the medications as an intermediary between your employer and the patient, and they're not allowed to release records back and forth. So the way it's set up is a bit convoluted, but essentially we silo off information from other areas so that way patient anonymity in a sense is maintained. Like when I leave this clinic, I cannot discuss a person, like I can't reveal their name, I can't tell them anybody demographic information. It would be ethically inappropriate, and also I would lose my license, and that is the standard of care in Canada. You cannot break confidentiality.
Thank you so much for explaining that so well. So maybe coming on to the cultural competency part of it, maybe we're talking about cultural competency versus cultural safety. Maybe I'll start with you, Dr. Priya. How would you define culturally appropriate care in the context of HIV?
Right, thank you very much. For cultural appropriate care in the context of HIV is when treatment or when care is given to an individual who is positive through a more respectful, stigma-free, zero bias, 100% confidentiality, all right, using the true language this patient knows or and patient understands, and as well knowing that time is very important. So of course, be time conscious when delivering this treatment as well, and basically respecting the patient's belief also. So when you do all this, a patient tends to be much more, confident, and then ends up trusting you. So when you get to the point where a patient can trust you, a patient can, can confide in you, then you have attained a point where you say your treatment is good and it is culturally appropriate. The care is culturally appropriate. It is beyond just clinical treatment. That's the point. It is beyond clinical treatment. It is considered um, how cultural values impact disclosure, how it also impacts on treatment acceptance and on long-term engagement. All right. So cultural appropriate care means ensuring that the client is satisfied with your treatment without you being biased, stigmatizing the client, or making the client feel bad about their status.
Yeah, maybe William would want to add on to that.
No, I think Dr. Pri hit every point. I mean, we try to be as sensitive as possible to the needs of our patients, and everyone comes from diverse backgrounds, and we have to respect that.
Yeah, that's very true. I understand in some cultures, some may request to be seen by a male practitioner or a female practitioner. So in that context, would you say that the healthcare system is doing enough to consider these cultural context, especially looking at the HIV treatment plans?
So within the context of the clinic, if a patient makes that request, we will do our best in order to accommodate. We only have a limited amount of staff. So if a patient requests female only physician, we can do that. The only problem is it might be a little bit longer before they can actually see their physician. Or if they request a physician who speaks Arabic, let's say, we have a physician who can, and we would ideally pair them together, but then it would just require a little bit more patience in order to actually set up an appointment. We wouldn't deny a patient their preferences. It's more about what is logistically possible in most cases, because we do need to make sure our patients are seen, or if we can say, hey, at least see a physician, see any physician for one visit, and then we'll transition your care to another one that may suit their needs better. A lot of it's just getting them into care.
Okay. And the part about the healthcare system doing something, do you think it's enough? The systems that are there, do you think that enough is being done to actually consider that the cultural part of things, or do you think that there's more that can be done? If so, what can be done?
Personally, I think there could be a bit more. Like even the translation service
Mhm.
it's a godsend. And it is very difficult to roll out in different settings because of cost. Our clinic is also kind of unusual because we waive fees just for your physician's visits on a compassionate basis. A lot of clinics will not do that, right? So even simple things like just removing certain monetary incentives is conducive to better care. And a lot of it is just requires more funding. Unfortunately, that doesn't really exist. So we do what we can, and there's definitely more that can be done.
Oh yeah. So I think the more of the questions would just be coming back to you, William, because you've actually been doing more of this work uh, with people coming to the clinic and having uh, to seek services from you. So I think my next question would be maybe if there are some programs or examples of programs that you can share with us or practices that have successfully integrated culturally appropriate care And if there are any, of course. Yeah.
That I'm not too sure. So the
Mhm,
best person to probably redirect those questions would be our social worker. So
mhm,
the SIS clinic has social workers who are always part of the patient circle of care. So
mhm.
when a patient comes in, they'll see the social worker first, and they'll be the one to link them to certain programs or other kind of things that they can be a part of in order to improve their care. So I know that there have been some initiatives to help individuals with who are of color, just in terms of funding, a little bit of assistance with food and that sort of thing. The social worker is the one that coordinates that sort of aspect of it. My job is mainly limited to medications. We do
Okay.
attend kind of conferences as well, where they promote these services, and they also kind of share experiences between HIV practitioners, but they do vary quite wildly between clinics. So if you have anything you want in the community, or if you have any kind of needs outside of the clinic itself, the social worker is kind of your gateway to accessing all of that.
Okay. Well, yeah, that's interesting, eh? So I'm just thinking that, the if there's this consistency in a way things are being done, you build that kind of trust between you and the ones coming for services to you. Maybe this I can also throw to Dr. Priye to say, in what ways can service providers actually build trust with the clients from diverse cultural backgrounds, like who would want to come and get services? Because in a way, if there's a lack of consistency in the way services are being provided, there's that lack of trust. For someone might just say, I'm not going back to the SIS clinic because the last time I was there, they did this, and then the last time I went there, they said they didn't have that, you know, just as an example. So I would want to know what you think service providers can actually do to build that trust or and to maintain it with clients coming for services. And we're talking about the clients who are coming from a different background.
All right. Yeah, clients from different background, how can you boost their trust? All right. First of all, you should have the knowledge of a professional healthcare worker. All right. Most of these clients coming from different countries might have gone through different traumas of
Mhm,
stigmatization, of judgment, poor judgment, of discriminations, and so on. So when these clients come to you, all right, as a
mhm,
professional, you should be non-judgmental. You should be soft-spoken. You should show empathy to this client's current condition. And you should show that you truly care and you are here for the client. That is why you are in the office, because of this client. All right.
mhm.
You should let them know that you are here to serve them. You should ensure that whatever you discuss with the client remains confidential. Most healthcare workers they are meant to be newscasters and not healthcare professionals, because some of them talk a lot. All right, they leave the office, they go out, they explain to their colleagues that they met someone who is this, who is that, even mention the names of these people. So this tends most of these clients, all right, must have heard of these stories of healthcare professionals disclosing people's status to outsiders, and it makes them to be very cautious of where they go to access treatment. That is why you see that most people prefer to go to a very far destination to access treatment rather than going to a very close by healthcare hospital nearby, just because they don't want anyone who knows them to be present in that particular facility, which is why they go so far. So you should eradicate stigmatization whenever you're dealing with them. You should ensure that all you discuss with them is kept confidential, and don't just talk about HIV whenever they come to meet you, or when they come for a form of counseling or whatever. You should go outside a little, talk about their jobs, talk about their families, get to know them more, be friendly actually. All right. They don't need to be your friends, but you should be very friendly with them. Okay. Try to, dance around a little, not just HIV. Of course, the aim is to ensure that they leave your office satisfied, all right, with whatever they need. But you can just, talk about every other part of life with them. All this you are doing is just to gain their trust. So when you've gained their trust, they will be very open to disclose whatever you want, to tell you whatever you want without any form of hindrance or any form of them being scared that you might go out and tell other people. So be calm when talking to them. Ensure that you before they leave your office, they leave satisfied. Show empathy. What is the way forward? How can you ensure that all the questions that they come to ask, you answer it, and you answer it to the point where they are okay with it? So if you can do all this over time, trust comes over time, not just one day, it builds up. So if you can do all this continually and ensure that not just you, every other healthcare provider or healthcare professional, all right, are meant to be trained on the ethics of treatment. You don't go around telling people about people's status. Whatever happens, you keep it to yourself. Even if you are treating your brother, you don't go and tell your parents about your brother's status. That is how far it goes to be confidential. These things make people to hide in their shell. Now, when these clients, they hide in their shell, they don't come out to get treatment. Some don't even let people know about their status. Now, when they don't get treatment, when they don't know, let people to know about their status, they start to deteriorate because the virus starts to increase because they are out of medications. Their viral load tends to go very high, above 5,000, 10,000, and so on. They can even go to the point where they become AHD, advanced HIV disease, with other co-infections like tuberculosis and so on, because they are scared of coming out. They are scared of being, discriminated. All right. So you need to ensure that all these are set in place. As a healthcare professional, you should be professional. And when you're professional and you do what you have to do at the right time, then these clients will drift towards trusting you. And when they trust you, you should ensure that you don't break that trust, because when you break it, it becomes very difficult for them to trust the next healthcare professional. So if you fail them here, it might be difficult for the next person to build up that trust again. So whatever you're doing, you keep it clean, you keep it true, and you make sure that they are everything is kept confidential, and you are friendly with them. You go as far as discussing about other part of life with them, not just about HIV, and then you're going to gain their trust. Thank you.
Thank you so much, Dr. Priya. William, do you have anything else to add to that?
No, I think he hit on quite a few important points,
Mhm.
and I very strongly agree. Trust takes time, and time, unfortunately, it's hard to carve out time to see everyone to the degree that they need. But
Mhm.
the clinic doors are always open. Our patients are always open to engage with us whenever they feel like that they need it. And we try to meet them where they are. So not every patient, especially at their first few visits, want to talk to me or want to tell me anything. And that's okay. You don't have to tell your healthcare practitioner anything you don't want to. And
Okay.
that's an important thing to keep in mind as well, especially for newcomers. If you're not comfortable, you can say, I'm not comfortable speaking to you about this yet, and we will accept that.
Thank you so much. Sarah, do we have any questions in the question and answer that maybe
Yeah.
uh,
Yeah, one so what would you say makes Canadian HIV care different from HIV care in other parts of the world? So like William mentioned different medications, but are there other areas that you would say, like, as people are adjusting to becoming Canadian, what do they need to know about their care and living with HIV in Canada that they may have no idea about?
So I don't know exactly how other countries provision their care. I know the medications that they have access to and the differences, but I mean, just from personal experience, I've found that patients who are coming from other countries, their practitioners aren't they almost don't seem as involved in certain cases. So they're not as aware of how HIV works, or they're not kind of spoken to as much about just like what HIV as a virus is, or its potential impacts outside of just, hey, take this medication and you'll live. Like some patients I've spoken to, they come in with almost very little knowledge of what HIV is as an illness, outside of they need to take medications, which is important, but I think education is essential. If you don't know why you're taking this, you won't understand the implications down the line for how important it actually is.
Okay. You want to, Sarah?
No, that was a great answer. It did make me think of also, so in terms of things like disclosure in Canada versus other countries, are there educational pieces that like an organization such as ours, Positive Health Network, should do more around helping them navigate where, when, laws, all that, those pieces. I'm just seeing that, think that it's just bringing that to mind and wondering if there's, from your interactions with clients, if they've been surprised or found something unique. I mean, you said, William, that they really didn't get as much attention or as much education. So that is one piece that we seem to be doing well or a little bit better in Canada. But if there were any other areas like that that other aid
Well,
organizations could fill the gaps on.
legal disclosure is complicated, I think, in Canada. So if you are fully suppressed, you have no risk of transmission. There is no legal need to disclose. However, if you are viremic, if you have that risk of transmission, then there is that need to do so. So whenever there's any kind of legal concerns, we usually refer to HALCO, because they're actually lawyers. They will know exactly what you can or cannot do in the context of HIV. And um, they do it on a consultancy basis. So it's a free service, and I think it's an essential service, because navigating a system, especially a healthcare system, has a lot of laws, rules, and regulations, and they're there to protect both the practitioner as well as the patient. Um, and and I think in terms of disclosure, it really comes down to that piece of, are you suppressed, or are you on treatment, or are you not? And for the vast majority of our patients, because they come in on treatment and they're already suppressed, the disclosure requirements are different. So that's something that they'll have to kind of decide on. Do I tell somebody that I have HIV? And it becomes a choice for them rather than a legal obligation.
Thank you. And when you have to change medications because we don't in Canada have certain ones, can that be difficult for like a difficult process? Because I know culturally, some people prefer pills, some people prefer injections, some people. So how does that look? Like if you're like, okay, you have a few more weeks of this, but then we're gonna have to roll you into something totally new. How do you decide to what to do?
So that's the fun part. Um, Different medications cover different conditions, right? So TLD will cover HIV, but it'll also automatically cover hepatitis B. So if hepatitis B is something that is a concern and endemic to where you're immigrating from, or you've been exposed to it and there's some medical records of it, that limits our choices for what we can give you here. Generally speaking, though, Canada is very well resourced. We have options that wouldn't even be available outside of Western aligned countries. So finding something that works is relatively easy. But the biggest part is coverage, in terms of just making sure that there's a way to get these medications paid for rather than out of pocket, because their costs are exorbitant compared to outside, as well as making sure that, clinically it's appropriate. Like the injectables that you mentioned, shipping them between different facilities is difficult. You have to keep it between 0 and 9 degrees, or you have to throw it out. And that is $2,700 wasted. So these are kind of logistical concerns, and it doesn't cover hepatitis B, and you have to have not failed a previous regimen, and you have to be suppressed. Like these are all clinical considerations that we take into kind of account when patients come in. And it's usually why patients don't come in and we swap them to injectables right away. We usually go with something that's an oral medication that covers the conditions that they may have or that are more likely to succeed for them or are equivalent to TLD on a individual basis, but more robust, so on and so forth. So we try to transition them to appropriate choices based on clinical criteria.
Okay, that was very informative. So Tim has a question. I'm going to allow Tim to talk and ask his question.
Great. Thank you, Mercy. Thank you, William and Doctor. We're very happy to have you join us today. So my question back to William, what you mentioned, and I know this is the case now, and it's really good overall that the obligation to disclose of the patient or the client has reduced because of the changes and the developments with being undetectable or low viral load, as you mentioned. But I don't think the requirements have changed for public health. Is that true? Or physicians in terms of having to report
I
a
believe
positive
public health
result?
keeps an eye on everything. Like every time we do any sort of laboratory testing, public health is aware. So they would still know, yes.
Right. So that part hasn't changed. So I mean, there's two sides to that. I suppose it's important that we have accurate numbers.
Mhm.
So reporting for that reason is good, but there's still the other side of it, that what additional steps might be taking when someone's result is reported to public health.
Sir, what do you mean by additional steps?
Like they used to do tracing. They would do follow-ups with people,
Right.
public health, that kind of thing.
Yeah, so usually I think they still do that. We tend to try to avoid talking to public health as much as possible in terms of just what we need to tell them. A lot of time it's contact tracing for STIs that we check for in the clinic. For HIV, I believe they only care if your viral load is above a certain threshold. But in general, that goes through our nursing staff rather than myself. So
Right.
I actually don't need to be the one to speak with them.
Great, thank you.
All right. Thank you so much, Tim, for your questions. Yeah, very insightful. Yeah. So my next question would be maybe around community. If this is directed to you, William, Dr. Priya will probably have maybe other things to add on to that on ways that we can involve community in the design of HIV care, design and delivery, of course, of the HIV care. Are there any programs that you're doing with communities, or do you involve community maybe in trying to get their perspective or their contributions in the way that you give services to people living with HIV who are also coming from a different cultural backgrounds?
So personally, I don't.
Okay.
With my obligations, I am tied to the clinic itself. So I can't really treat anybody who is not a patient of the SIS.
Mm-hmm.
Outside of that, if patients do come through the hospital staff can consult me in terms of HIV care. So if they have an HIV positive patient and they're asking for options, recommendations, changes, or issues with whatever they have on formulary with respect to medications, I can weigh in on that. Outside of that, my hands are kind of tied.
Oh, okay. So maybe my question would be more of, do you like the model, the service delivery model that you use at the SIS clinic, is it by any chance influenced by maybe contributions from people outside of the clinic?
So, I mean, in terms of pharmacy, which is kind of the only thing I can actually speak to, I'm
Mm-hmm.
part of the Canadian Hepatitis like there's a chat group. It's Canadian pharmacists who are dealing with HIV and with hepatitis patients. So any kind of political advocacy, especially with things that are happening in the States,
Mhm.
will be a little bit a part of that in terms of just provisioning what's important and also like requesting changes there. Like right now, they're worried about guidelines and how those things are being affected. We also kind of communicate with each other in terms of clinical cases. We'll also kind of discuss with each other at annual meetings about how we provision care to newcomers to the country, any trends we've noticed as well, or kind of those things, but it's not really as formal as I think
Okay.
what you're asking about. A
Yeah,
lot of
of
it
course,
is
yeah.
just professionals communicating with each other, at least from where I come from as a pharmacist. And it's more like, hey, these are new clinical cases. These are the resistances that we're noting in the new immigrant population. These are the kind of medications that seem to be failing, or like there's some sort of outbreak in certain provinces. So this is kind of what I bring primarily to my practice. It's almost more like an epidemiological view of these patients. It's like, what exactly is going on out there? And
Okay.
will that change our choices that we give to patients?
All right. Yeah, that makes sense. And maybe looking more at agencies like ours, like Positive Health Network, we're an AIDS service organization. We work with communities. Um, there's a lot of stigma out there, you know. So maybe this would be directed to Dr. Priya. How do you think we can better involve the community in the design of HIV care and delivery as well? I- At the same time, also protecting the confidentiality of our clients as well.
All right, thank you very much. So it is very much important to involve the community members in the management as part of the management, HIV management team, in the sense that they are more grounded, they know the terrain better off than most of us. So they can easily access most of these areas to to get people, to inform people about HIV, or maybe put out outreaches over there, peer-to-peer works. They can also, we can involve them in a kind of module, like design programs, design workshops, and so on. All right, because we call them the grand roots of the program. So these people, when they get a client in the community, or when they get someone, they can easily link this person to the facility. There will be like a middleman between the community and the facility, in order for us not to lose out on some clients, because most clients would not want to walk down to the facility to get tested. But when there are outreaches, when there are programs done in the community by the community members, people tend to get more involved. People tend to get more enlightened about this infection, and they might even get tested immediately. I don't know how it is done here in Canada, but in my country, there's what we call the community outreach, that is done by the people from a particular community. You know, some persons choose to trust their people more than even strangers to get them tested. So when this outreach is done, people get tested at the spot there, but in a confined space, all right, where their status or the outcome of the test will be known to just the tester. All right. Now, for those who turns out to be positive, those ones are then linked to the facility for further management. All right. Now, it is important because if you are just in the facility, you might not be able to cover up the whole space that you need to cover. All right. And when you include these community people, you tend to cover up a whole margin, which is the aim. There's we call it 96, 96, 96, which is 96% of the people who are HIV positive to know that they are HIV positive, and 90% of those who are HIV positive to be in care, and 90% of those who are in care to be virally suppressed. Now, for you to be able to cover that coverage of 96%, you cannot do all in the facility. You need the aid and help of those in the community because they know the terrain better than you who just stays in the facility, and they can access more areas. So involving them is a very beautiful approach to curb the spread of HIV in any organization, in any state or any country, because it will be very helpful to be able to reach more persons than you will do on a very normal day. And of course, they will get some compensations for their work done and so on, which will also boost them to want to continue doing what they are doing. So I think it's a very beautiful thing because it will help you to reach more people than normal. Thank you.
That's very true. Thank you so much. There's power in numbers. I want to believe. Thank you so much, Dr. Priya, for that. I guess so. Moving forward, I'll throw this one to you, William, first. What do you think, or do you think that service providers need any training or support to implement culturally safe practices?
So every practitioner is essentially responsible for their own practice. It's all independent. And even in the clinic, the practitioners aren't actually sharing patient info with each other. So
Okay.
we can mention, hey, like Dr. Ahulu might have had a patient with unusual kind of viral load counts, but we can't say who it was or anything related to that, right? So a lot of that is your practitioners kind of develop their own sense of what is culturally safe, right? And I'd argue that their approaches to therapy is different from that. There's no universal standard from what I
Yeah.
can tell. From the conferences and the talks that we go to, they do promote certain things like creating a safe space, making sure that you remove as many barriers to treatment as you can, ensuring that patients are comfortable and that you spend enough time with them, assuming that patients who come in have experienced trauma, as Dr. Priya has mentioned, which is, and it seems to be kind of the universal sort of expectation that your patients are coming in having experienced trauma. But how we approach it is a little bit different. Like we have one physician who's an addictions expert. So she tends to have kind of patients with drug addiction issues. We have other physicians who have been basically in the business of treating HIV for over 2 decades, right? So all their approaches are different. But I do believe that overall there's a sense of cultural sensitivity that we all try to engage in. How that manifests is unfortunately not standardized, but each one kind of tailors them to our patients as best we can. So it's essentially all we can do. I don't believe there are any real guidelines for how to be culturally appropriate and culturally safe. We just try to create an environment that is open to everyone.
Yeah, that is very interesting. You actually brought back memories from the first webinar that we had, and all our panelists actually agreed that every situation or every person is unique, and so we talked about how uh, healthcare providers in some spaces just tend to treat people the same way because probably they come from the same country or they're of the same skin color. So now that you've actually pointed out to that to say, these things are contextual, each individual is different, you then treat them differently, it actually, makes me happy. And also, I'm sure they're also part of this webinar and they're listening in and they'll be happy to hear that, that's the way the services are being provided to people. I'm not sure about Dr. Priya, if you've got anything else to add to that, what you'd suggest, maybe support, or if there's any training that you think healthcare providers should receive for them to be able to better serve in a culturally safe way.
Yes, Dr. Thomas Williams has said plenty, but I think from my own end, training is needed. It is needed because I have seen cases where we assume that a healthcare professional knows what he is doing and ends up going against the ethics of confidentiality of a young girl. She came in, that was in Nigeria. She was positive. Now, because the healthcare professional tends to be friends with her elder brother, he went ahead to disclose the information to her elder brother. All right. So we should not work with assumptions that anyone knows or is abreast with the guidelines of working as a professional positive care worker. All right. No, I think there should be training for them on, interval training and retraining and refreshments and so on. Refresher training should be conducted in terms of not just confidentiality alone, in the mode of operation. When a client comes to the facility, all right, how will this client move throughout the facility? All right, you might not even speak, but your body language might even tell a kind of judgment, without you even saying anything. All right, so healthcare professionals should be trained in the aspect of working as professionals, as they are called. All right, not just yeah, how are you? Are you okay? Okay, take your drugs, do this one, yeah, and then you leave. No, 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 no. You should know exactly what to do. All right, don't treat people as like they are trash. You don't treat people like they are of less value because they need your services. You don't do that. So you treat everyone the way you would love to be treated if you are in that situation, if you are in their shoes. So people should be trained on that ethics. People should learn on how to do the right thing at the right time. You don't look down on people. All right. So I think it is very much important for them to be trained on the optimal and best practices of how to manage HIV patients. Thank you.
Thank you so much, Dr. Priya. I also believe that learning is never ending. So, like, as you go with the patients and stuff like that, you meet different people. You also learn from one person, and probably you transfer the same, way that you treated the same person, and maybe do it better with the next patient. So I'd like to believe that, yeah, like you said, William also alluded to that, to say every person is different. Even as a service provider, you know how to treat a person in a different way, because they also have different needs, and that's really good to hear. I'll start with you, William. How do you think that AIDS service organization like ours, Positive Health Network, can actually create spaces for newcomer voices in policy and program design?
Well, I think out of all the kind of providers of HIV care, you guys are first line in terms of just seeing your clients directly. You a lot of times I've seen Positive Health Network bringing our patients to us, removing barriers, bringing them groceries even, or even taking them shopping. Like these are things that I think you do very well, and I believe make a huge impact in terms of actually finding what they need, right? You'll be able to identify things outside of just medications, which what exactly are they struggling from? Is it an integration into the healthcare system or Canada as a whole? I remember speaking with my colleagues that there is apparently loneliness among HIV positive patients because they are afraid of disclosure. And it's not just limited to newcomers, it's everyone. So they are afraid to interact with other people, right? So then while it creates opportunities to identify gaps, I think advocacy, I think, would probably be your best benefit in terms of helping out patients. It's like, hey, this is an unmet need. We need to kind of look at it and see if there's a way to support these patients.
Thank you so much. Because I was going to ask you next, what role you think advocacy would play in transforming the whole system in HIV care, and maybe foster inclusivity and responsiveness. So I think you've already answered that part. Sarah, do you have any questions in the question and answer or questions from you? Or if
Yeah,
there's anybody
one
who...
other question that ties back to the very beginning. So, what happens, like, what role does immigration play? So say someone's coming in and they knew they were positive ahead maybe, or they didn't, but they had so much trauma and they're just so exhausted and maybe they're depressed, they're far from their family, um, and they are just focused on getting food and shelter and they don't want to deal with their HIV right now. So what happens? I mean, that is not optimal, and we want to do everything we can to prevent that for them. But do they, like, is there a risk that immigration would get involved? Do we know? Or that, the public health would follow up with them? Would there be pressure around that?
That I'm not sure. When
For your safety.
Sorry, pardon?
Sorry, I think,
But that was just a, yeah.
yeah.
Yeah. So in terms of just what immigration does, I'm not too sure. Like immigration, when we see patients who have been referred to us through immigration, it's because they've tested positive on immigration. So these patients, when we see them in the clinic, they're already kind of engaged in care. And most of them are going through the process of becoming permanent residents or obtaining citizenship. So discriminating people based on HIV status, I don't believe is something they do. But whether or not that impacts their ability to gain Canadian citizenship or permanent residency, I believe it's usually other criteria. So for that, your best person to ask would probably be Helco. And um, yeah, and unfortunately, I don't really know too much in this case.
Okay, thank you.
Thank you. Thank you so much, William. I think we've lost Dr. Priya. Do you have anything else that you'd want to just maybe say as we get to the end of our discussion?
I think the only thing that I've always, I guess, tried to maintain, at least in my practice, is if a patient comes in and I'm not asking them to trust me, I don't ask them to tell me every little thing, and I don't expect them to disclose things to me, especially if it's only been a few interactions.
Mhm.
But what I want them to do, what I do want them to trust is that what I say I can do for them, I will. So they don't have to trust me, they just have to trust what I can do for them. And if I make them a promise, or I make them a guarantee, or if I make them like if I show them that I can do something for them that will benefit them, I think that's important in terms of establishing care. So if someone needs something and you see me and you see me in clinic, ask me if I can do it for you, and I will be as honest, transparent, and as effortful as I can in helping you out if I can.
Thank you very much, William, and welcome back, Dr. Priya. So we're just rounding up, and would want to hear from you if you've got anything else to say, maybe any suggestions or anything that you'd want to say, regarding our conversation that we're having today.
All right, yeah. Yes, something I would like to say is that the how would I say the health sector here is doing very well in terms of um aiding ease of access of medications of or care to positive clients. They are doing very well, especially the health centers. But the mainstream needs to do better in the sense that they need to train their healthcare professionals more. How? Language barriers. You need to include people who speak more language, just as William said earlier. Two, people who are keen on getting the job done, not people who are just there to take home salary. People who truly care about the work. They should be the ones at the forefront, because humans we are not like cars that when a part spoil, you can just replace it and it's back to new. You can't do that with a human being. A human being is fragile more than just mere cars and all that. So it is very, very important that we have the best of hands at the forefront to ensure that the best form of management is given to those individuals who truly needs them at every point in time. So if we can do that by getting them training them, after you employ, you also train these people on the ethics. I have been saying it because I have seen where these things lead to too many problems. The true ethics of managing these people. Confidentiality is a very important thing where most people get it wrong, because the moment a client feels stigmatized, they stop coming. Now, when a client stop coming, you are trying to curb, say, spread of a particular virus. Yeah. Now you are giving this treatment to a client so that this client will be virally suppressed. Then these clients start taking these drugs, become suppressed, and then stop taking this drug. And of course, the client immediately becomes unsuppressed, which we don't want. Now, if a client becomes unsuppressed, transferring this infection to the next person becomes very easy. So you see, all your work done goes back to ground zero because of one mistake that you did. All right. So instead of you curbing, you're even expanding the virus, spreading it everywhere. So we need the best of hands around to zero stigmatize, to keep confidentiality at 100%, know the right medications to give at the right time. Like in Nigeria, we use TLDs, tenofovir, lamivudine, and dolutegravir. I don't know what we use here in Canada. I think William should know that. So I think it is way much important for us to be able to do all that. If we can do them, then trust me, we would have a very good system here. And I think that is what I have to say for now. Thank you, and over.
Thank you so much. Thank you so much, Dr. Priya, for that. Do we have any questions from
Nope.
anyone who's attending? Do you have
No
any questions
questions
in the
in
question?
Q&A. Sorry,
No questions from you, Sarah?
no further. Thank you.
Anything, any last words from you?
No. Oh,
Go ahead.
All right. Thank you so much, William, and thank you so much, Dr. Priya. This was a very enlightening conversation, and thank you so much for taking your time to be here. We've got a question. Did I see a hand up? Okay, I will allow Neha to speak. I don't see it anymore. Okay, I will allow Neha to speak and just give him the floor to ask their questions. I don't see the hand up anymore, so I can't allow you. You've got. Maybe you can put your question in the question and answer, Neha, and then Sarah can read it out. Because I did see your hand up, but I don't see it anymore, and I won't be able to allow you to speak if I. So hopefully we'll have the question in the question and answer, and then Dr. Priya or William can answer the question.
Okay, so she has a question about the myth around a 6-month injection coming. Oh, so the 6-month injection comes myth.
okay. I've heard this from numerous patients right now. There is no 6-month treatment yet. Right now, the only long-acting injectable treatment is Cabenuva. It is every 2 months, and that's only after you've done the 1 month separated loading dose, and then it's every 8 weeks. And for that, you need to be already virally suppressed in order to switch over. So those are the kind of general gist. What's in development is every 6-month injections. There is one, it's called Sunlenca. They're also using it for PrEP. It's called Yestugo. They're both the same thing. It's lenacapavir, and that is a one portion of a full treatment. You get an injection every 26 weeks, but you are also on oral medication or some other component in order to ensure that you remain suppressed. It's for patients who are failing treatment. It is extremely expensive and very difficult to obtain, but it's more for patients who have essentially no other choice. Eventually, they'll probably pair it with another long-acting injectable, but we're looking at probably closer to a decade out before that is a reality. Unfortunately, I think a lot of what happens in the PrEP space, which is what Canada is, I feel, a little bit more interested in sometimes, is conflated with what's actual treatment. The every 6-month injection exists, but never on its own for a patient who has HIV. You still need a second, at the very least, medication on board.
Oh, thank you, William, for clarifying that. I also heard about that, and I also would have really wanted to know. Thank you so very much. Looks like we've got more questions. Sarah?
Yes. So Naya also asks, another question is, how important is it for a client to be connected and put on medication once they get diagnosed? And if they are newcomers, as sometimes there can be delay in appointment. I think William kind of covered this in the beginning, but is there any more to mention on that?
The sooner we get treatment started, the better the health outcomes. That's kind of generally what the research shows. So, like I said, we try to fast track patients as soon as we can. We try to squeeze or shuffle patients around so that way we can see them a little bit faster. But it's also important to ensure that they are started on on the correct treatment. I've seen a patient who was, I think, prescribed something from an urgent care center, HIV positive, but they never did an HLA test, so they were prescribing something that might just cause an allergy, and we didn't catch it until they came into our care, and we ran our panel of blood tests. So unfortunately, you need expertise to choose the right drug for the patients, and the ability to just squeeze them in is limited by logistics. Like, I think we can do better if we were able to petition more resources for it, but that depends on money, unfortunately, and finding that is way more difficult.
Thank you.
Yeah.
Thank you, William, for explaining that so well. If there are no more questions, I would like to thank you, William and Dr. Priya, for being our panelists today and taking your time to, share your knowledge with everyone who is attending. I'd also want to thank our attendees. Thank you so much for being part of this exciting conversation. And I'd like to thank Sarah, my co-host, for being amazing and holding fort while I'm here. Thank you so much. If there's nothing else, I'll be ending the session, and I will keep thanking you guys. Thank you so very much for being part of this.
Well, Dr. Priya has his hand up, I think.
You do? Sorry, Dr. Priya, you've got your hand up?
Oh yeah.
Oh, okay. You
All
can go
right.
ahead then.
Okay. I just want to ask William a question because I don't know how it works over here. Do you guys do like a recency testing?
Sorry, what do you mean by recency testing?
All right. It tells if a patient is a previously known client or the patient is an actually new client. All right. Some people tend to, lie that it's their first time for them to know that they are HIV positive. So what we do in Nigeria, there's what we call recency testing. Now you take this patient sample and then you test it. All right. If the viral load is high, above 1,000, if it is high, then that patient is actually a new patient. All right. But if the viral load is low, it tells that patient is on medications already. All right. So it's like you test at the point of enrollment. That's when we do the recency testing, just to rule out the clients who are, shady, kind of, some people can be very shady, So we do that to just rule that off. So I don't know if such practices carried out here in Canada.
So the SIS does not do recency testing. That is not a part of our standard tests. We run viral loads, flow cytometry to determine CD4 cell counts, hepatitis B, hepatitis C panels, as well as venereal disease screens as well, just because HIV, hepatitis, and all of that fun stuff is unfortunately STI, like sexually transmitted. So we do that testing. A recency test we don't do, although we do look at results, and occasionally it does raise flags depending on how your values are. So if you were recently diagnosed, unless you're acutely seroconverting, I do not expect your CD4 counts to be so obscenely low that it sounds like you are now at the point of AIDS. We also look at kind of viral loads itself. We see it spike up to 1 million if you're acutely seroconverting, or if your immune system is already collapsed, right? So it depends. The highest viral load I've ever seen in my life was 10 million plus, and that was just because the lab itself cannot quantify any higher, but that was a long-standing patient, right? It was unbelievable. And from a clinical point of view, it's very interesting. But we know their history and we can see their CD4 counts, and then we can guess. We don't do a recency testing because generally we like to believe what our patients tell us. If they're telling us, hey, this was a long-standing issue and your lab results corroborate that statement, I am less likely to keep as close an eye on your future labs because it makes sense. If somehow the labs don't seem to correlate with a self-reported kind of issue, then I'll just pay more attention. The treatment remains the same. So we still treat you. We keep you as engaged in care with the clinic as possible because it is the best thing we can do to ensure health outcomes. I'm not going to discriminate against someone just because they feel like they can't share that information with us. They might have a reason for it.
All right. Oh, thank you. Thank you for that question.
Thank you so much, William. Thank you so much.
All right.
Yeah.
Let me know if you guys need anything else. Thank you very much for having me.
Thank you so much. Thank you. I think we'll be ending our session now. And thank you so much. Thank you for being part of this.
Thank you. Bye-bye.
And thank you to Tatenda for your your encouraging words. Thank you so much. I'm seeing compliments in the question and answer section. If there won't be anything else, I'll be ending the session. And thank you for attending to everyone. Thank you so much.